Welcome back to the third part of the Adult Asthma Guidelines. My name is Richard Beasley, and my task today is to briefly review the recommendations in terms of the assessment and management of acute severe asthma. I think the most important concept in terms of assessment is that this is best achieved through objective assessment of lung function, either through the measurement of FEV1 or peak flow rate, that the measures are expressed as a percent of predicted values, and these can be used to most accurately determine the severity of an asthma patient, and that then guides the initial treatment that the patient will receive. And then the next most important feature is that the response to the initial treatment is the really firm determinant of whether a patient is likely to need referral or admission to hospital. So nothing much has changed in terms of the assessment and the recognition of moderate and severe asthma. If we turn to severe asthma, most importantly, that this is recognised by an FEV1 or peak flow between 30 to 50% of predicted values, a respiratory rate of more than 25 breaths per minute, a heart rate of more than 110, and difficulty in completing a sentence within a breath. And so the recognition of life-threatening asthma is relatively straightforward and very similar to previous guidelines. And I think the most important point is that if the patient has any of these features of life-threatening asthma, then they could be considered to have their life at risk. And perhaps the other feature to mention is that the lower features with an asterisk, they are really very late stages of a life-threatening attack, and they're really an indication of an imminent respiratory arrest. If we turn now to the criteria for hospital referral or admission to hospital, these are actually fairly straightforward as well. So if a patient has any feature of a life-threatening attack of asthma, then they require immediate referral and admission to hospital. And likewise, if a patient has a feature of severe asthma despite initial treatment, then that is also an indication that the patient is likely to require admission to hospital. But as we all know, asthma is complex, and there are many other features that we might need to consider, primarily relating to adverse risk with individual patients that may lower the threshold in terms of deciding that this patient it would be preferable for this patient to be referred to hospital for consideration of admission. And so what are some key practice points we might use to recognise patients who are likely to require referral or admission to hospital? Well, I think if we were going to ask one question, it would be how many puffs of their beta agonist had they used in the few hours prior to presentation. And this is a very good guide in terms of not only their likely requirements for treatment, but also whether they are likely to require admission to hospital. And in terms of what you can do once they have presented, it is the level of response to initial bronchodilator treatment that you administer to the patient that is a very good guide to the requirement for hospital admission. And so if the patient has a minimal or no response to initial bronchodilator therapy, that is a clear indication that they are going to require a period of inpatient hospital care. And so what are the important points in terms of the therapeutic approach to acute severe asthma? Well, the first one is that most patients can be adequately treated with a short-acting beta agonist via a metered-dose inhaler delivered through a spacer, together with oral prednisone, and that nebulized bronchodilator can be reserved for patients who don't respond well to initial bronchodilator therapy. In terms of intravenous therapy in the hospital emergency department setting, that there's no standard role for intravenous beta agonists or intravenous theophylline, and that if one wants to turn to intravenous therapy, one would choose magnesium. And finally, that there is no role whatsoever for adrenaline unless there are features in the asthma attack to suggest either angioedema or anaphylaxis. And so an algorithm has been provided for the assessment and management of acute severe asthma that has been in a format where we hope it can be used, for example, as a wall chart or something that can be easily accessed in a place where you may treat patients who present with acute severe asthma. The key initial approach is to assess asthma severity and then determine whether you're going to go down the mild to moderate, the severe, or the life-threatening attack of asthma pathway. The one then administers the bronchodilator therapy and steroids as required. And then the next key feature is assessing the response to that initial treatment, because that is really the main determinant of whether the patient will need to be admitted to hospital or who can be safely discharged. And of course, for the patients who have a life-threatening attack of asthma, which is recognised right at the outset, that they would go down their own pathway in terms of very aggressive high doses of bronchodilator therapy, along with systemic steroids, and the very prompt transfer to hospital for admission to a HDU or an ICU setting where they can receive the intensive management that they would require. And so for those patients who do not require admission to hospital or referral to hospital, it's really important that a number of issues are addressed prior to their discharge from your care. Most patients who present with severe asthma, they are likely to require a course of oral steroids, and prednisone in a dose of 40 milligrams daily for 5 days is the best standard regime that can be used, and there are very few patients who might need a longer duration of therapy. It's a really good opportunity to address the issue of inhaled corticosteroid therapy, particularly if the patient has been poorly compliant or the patient is not already on inhaled corticosteroid therapy. This is a good opportunity. They're often more receptive to advice about long-term management, having presented with a relapse or severe exacerbation. And so this is an opportunity to reinforce the use of regular inhaled corticosteroids, or if the patient is not already on inhaled corticosteroids, to start this form of therapy. And I think it's also important for the patient, before they're discharged, that they're given advice as to how to recognise worsening asthma, either through worsening symptoms or through a further drop in their peak flow rate, to determine in particular when to seek further urgent care, and also to provide them with a fairly early follow-up appointment so that you can further manage the exacerbation of asthma to ensure that they make a full recovery. And so that really is the brief standardised approach to acute severe asthma, and that is the end of the series of 3 presentations. I hope you found the presentations helpful and that you have the opportunity to download the Asthma and Respiratory Foundation of New Zealand Adult Asthma Quick Reference Guide, and that you can use it as a standardised approach to the management of the adult asthma patients under your care. Thank you.